circle of Willis, and they
Good
applied
morning.
some
This is a
conditions.
recorded
Oh,
talk. My name is Dan Saleh. I'm a consultant up in Newcastle.
sorry, what happened here?
My brief is integrating digital technology into reconstructive practice. So I guess I'll talk a little bit about what I think the direction of travel may be and the things that certainly I work in, commercialize that things as well. So currently, as it stands, our surgical training centre has a number of collaborations, and we host one of the country's robotic training centres as well involved in that. And I do disclose that I have received honoraria from companies in the past, and I have an active role in a digital company based in Europe. So first of all, what can work and what can't work? So there has been a boom in digital platforms and digital things that we can use in healthcare in general, and that's parallel with what I guess it might be the elixir of artificial intelligence and how that can and can't help us. So there's a lot of noise in this space, but is that translating to things we can actually tangibly use? The medical device regulations, I think, are here to stay. It was historically
You can hear me.
directive,
Sorry, I don't know what's
but
happened.
I think certainly the MHRA and
Hmm.
our sort of NHS England are certainly aligning themselves with using that as a template to test these devices. There is going to be some UK regulatory change because they want to still not hamper companies in developing these things. So I think there are changes in the offing, but they haven't come to fruition yet. So in general terms, how do we get something into practice? Well, if it's CE marked, that means that it's largely fair game. But if there is a price attached to hardware or software, then convincing an NHS department or an NHS trust to invest in it is quite hard. So they can come from charitable monies, but really the big hitters are either getting the company that thinks they've got value in their software or hardware, or both, to actually put the product in place for you with a translational research project in mind that they fund is the best way to do that. And you'd be surprised at how many quite high-end enterprises are not willing to do that, despite having on paper anyway the finances to do that. Parallel to that, certainly one of the digital innovation hubs in Leeds, just south of us, Alexandro Frangi, who's I guess a world leader now in silico trials, has cottoned onto the fact that it's very difficult to get the numbers of patients we need to upscale quickly to demonstrate a digital technology can help healthcare be used effectively. And so he's done some of the first big in silico surgical trials in the UK, some of them have been multinational, and they essentially recreate a clinical scenario using artificial intelligence with all the parameters that that clinical scenario may have. So, for example, they use lots of imaging from an imaging bank, intracranial MRAs and CTAs, to basically do an in silico trial of vascular stents. And that could be translatable all the way across from pre-marketing a product to getting it into the marketplace. So I think that will enter the fray with digital and other technologies that we may start to use in plastic and reconstructive surgery. The bread and butter, or the basic diet of things I do, is really computer-aided design for 3D planning, particularly of craniofacial and head and neck problems, and that's largely oncological in my practice. So we've gone, and I credit my colleagues, particularly Omar Ahmed and Mani Ragbir, who instituted this in our unit. And we've taken a few steps forward since then, but in essence, getting a very accurate 3D plan of the craniofacial skeleton, we can plan what we want to resect exactly, and then very simply put, we can get bespoke jigs where the cuts are very, very specific, and we get a 3D printed, milled, low profile plate. Because for those of you that's had the joy of chasing a bony flap that you have to osteotomize around a Mayo tray with a saw, and then bending or pre-bending a plate around a piece of tumour in a bone is not easy, and it can be a little bit crude, and probably the significant number of complications we had with plates being 2 or 3 millimeters proud of the neomandible or neomaxilla and then coming through the skin after radiotherapy is a fairly unpleasant a miserable place to be. So we've found that our collateral damage of these patients has become dramatically reduced. Not only that, but their operative times have been dramatically reduced by using these plans and these jigs. And we've used these primarily for lower jaw reconstruction, so the resective bit of removing the bone and then placing the jig on the fibular bone on the leg, and you have certain slots where the saw goes to make very accurate cuts. So the plate fits in the exact way it's intended to, and then also the green buttons that you see in the bottom left, they're dental implants. So once the patient's healed, hopefully got over their radiotherapy, we can implant teeth in their neomandible in one sitting, or two sittings in the case of radiotherapy. And that's been a bread and butter for us. I think it's a very common modality now throughout the UK. So we've taken that a step forward now, and we use it in some aspects to reverse plans. So patients that have major sequelae of radiotherapy, we have a sort of regional referral centre for osteoradiocrosis, and we now backward plan these 3D CT images, so we get an up-to-date 3D reconstruction, and then we template that onto a specific part of software which gives us the exact dosimetry that the patient had when they had radiotherapy. So it gives us a heat map of where the damage and the collateral damage may lie in that area of craniofacial skeleton. So in patients that have significant upper or mid-facial or lower facial defects, like the picture you saw previously, that does need at least a soft tissue reconstruction, but to what extent do things need to be debrided? To what extent do we need composite replacement of bone and soft tissue? Because there's no point in going in there and doing a reconstruction for it to, leave some tissue behind that needs to come away, and then you have a failed reconstructive effort despite having a successful free flap transfer, for example. Similarly, for patients that have acquired or congenital, but I've only used this for acquired, particularly mid-facial soft tissue defects following cancer ablation or following trauma. We have developed, using reasonably simple software again, subtraction MRI, where we can volumetrically marry the abnormal side, or the side that we want to augment, if you like, to the side that we're templating that on. And so the lighter coloured shaded area here, we can then 3D print an exact model of that tissue volumetrically, so not just in 2 dimensions on the surface of the skin. And then we can tailor our soft tissue reconstructions. This is particularly easy for buried free flaps, whereby we can try and marry the volume of the free flap to the 3D printed sterilizable model that we have. But occasionally we have even used volumetric models to give us an idea of the volume required if we were doing fat grafting restoration. And obviously that's not a finite science, and flaps can swell when they're transferred, and they also atrophy, and we obviously recognize that, whether it be not only muscle but even soft tissue and adipofascial. But this is all designed, certainly from my perspective, to try and reduce the number of revisional procedures that patients may need. Patients don't want to be coming for 3rd and 4th fat grafting efforts. They want to be having a definitive procedure, or at least the fewest visits to hospital as possible. The next iteration of this was nasal reconstruction. I don't think it's unique to the north of England, but certainly the cohort of patients I treat, they all see the prosthetist, they get a discussion with the prosthetist, and they see a library of images of nasal reconstruction in our clinic, and then they make a decision whether they want to go down a prosthetic or a reconstructive route. Nasal defects like this, which are primarily soft tissue, to a degree anyway, we normally always autologously recreate. But in certain patients that may have, for example, low foreheads, or may have had significant skin cancer surgery already in their forehead, having a very accurate 2-dimensional idea of what skin one needs, irrespective of the templates that we can get with paper or foil at the time of the definitive reconstruction, is very valuable. So we routinely now 3D print not only the preoperative nasal model if we've had a CT or an MRI done for that patient, which often we do for complex midfacial cutaneous malignancy or mucosal malignancy. And then we also unfurl that surface area of nasal skin into a two-dimensional template. And that's particularly valuable for patients that we offer single-stage nasal reconstruction because they've got many comorbid problems. And in general terms, we can go from having fairly significant soft tissue defect to, reasonably acceptable nasal reconstructions that are based on their original nasal size and template, and that can still give you the option, of multi-stage surgery when it's needed. So we've found that those patients that go down a multi-stage route can get quite significant improvement in their contours, but they also get a good result or something that is easier to reproduce in what can be difficult surgeries. We have been using ICG in our trust in plastic surgery for probably 3 or 4 years now, and that started with simple flap perfusion study to look at crude measurements of whether our flaps are well perfused. But we have 2 other tails to our work in this area now as well. One of them is looking at intraoperative tumour mapping, and that is primary tumour size, so giving patients an ICG dose perioperatively and then using the near-infrared camera to look at whether there is indistinct margins, particularly metabolically active tumours, where we can see ICG spill. And we've now got an NIHR funded study going for soft tissue sarcoma in that regard. We've also used it to reverse map potential metastases from cutaneous SCC in patients that are having significant, particularly head and neck ablation. And as an extension of that, we are trialing the new technology to actually quantify flap or tissue perfusion. So there's a near-infrared camera that will quantify the depth of fluorescence to give you an idea of how well a flap is perfused, not just that it is binary perfused, yes or no. And I think that will have significant growth and expansion, particularly probably in breast reconstruction, where there is always potential issues with fat necrosis and pedicle selection and size of flap and the volume that one needs for their end result. So this is an example of a patient that we had a significant SCC in the upper face with a CT scan proving metastases in the ipsilateral parotid, but we don't know what the other pattern of spread could be in this type of patient. So we inject the primary site with ICG, and then using the near-infrared camera, we can map and keep an aide-memoire map of where this drains, and then imminently, I think on this video, we'll just see if that orientates you where the ear is. We can see that the lymphatics coming behind the ear here into the postauricular chain. I don't routinely plunder the postauricular chain or occipital chain of lymph nodes if they're not grossly involved on the staging scan, but in this case we did take what were low volume metastases from behind the ear, so these were subclinical and radiologically not apparent, and so we are continuing that trial at present, but obviously we need big numbers to recognise a benefit. But certainly where there's heterogeneous views on how much or how little nodal tissue we should take from the parotid and the neck for patients that have just isolated ipsilateral parotid disease and SCC, or even Merkel cell or melanoma metastases, I think that this will have value moving forward, and it's a good piece of technology that we're using.